what I'm going to be talking to you about today is some of the work we're doing at Georgetown focused on expanding access and reducing barriers to genetic testing for cancer susceptibility. I think that my talk is going to be a little bit more clinically focused, because what we do is try to expand access within the clinic. I think my talk is also going to be a little bit more quantitative than some of the previous talks, but I think we'll have plenty of time at the end to try to put some of the numbers into perspective. So why don't I launch into it? Wow, those are not the colors that they were on my screen. So I want to talk about hereditary cancer, as I said, and I'm going to focus primarily on hereditary breast and ovarian cancer, but I do also want to touch on hereditary colorectal cancer. Hereditary breast and ovarian cancer, what I'll primarily be focusing on is BRCA1 and BRCA2, which are sort of the two most commonly mutated genes that cause hereditary breast and ovarian cancer. But as we all know, there are many more genes now that are associated with those sorts of syndromes. And then similarly, for colorectal cancer, I'll be talking about Lynch syndrome genes. A few things just to sort of put this all in perspective, I hope. Women who have a mutation in the BRCA1 or BRCA2 gene have an exceedingly high risk of developing breast cancer, as high as 70% or even more. High risk of developing ovarian cancer, up to about 40%. Men who carry a BRCA1 or BRCA2 mutation are at increased risk for prostate cancer. And in particular, if they carry a BRCA2 mutation, they're at increased risk for aggressive prostate cancer. The genes associated with Lynch syndrome are the DNA mismatch repair genes. And again, men and women who carry a mutation in one of these genes have an extremely high risk of developing colorectal cancer, again, up to 70% or more. And they're also at risk for a number of other cancers. So Lynch syndrome is associated with uterine cancer, for example, a number of other cancers. But I'm primarily going to be talking about hereditary breast and ovarian cancer. I want to draw your attention to the slice of the pie that I thought was going to be lavender, but it is now yellow. And that's the proportion of each of these cancers that are hereditary. So the proportion of colorectal, breast, and ovarian cancer that are due to a single gene mutation. And as you can see, it's a small proportion. It's 10 to 20%. So a low percentage of these cancers are hereditary. So why the focus on hereditary cancer? A number of reasons. First, these are fairly common cancers. So colorectal cancer and breast cancer in particular there are about 380,000 cases of colorectal and breast cancer each year in the United States. 10% of those, we're talking about 40,000 new cases of colorectal and breast cancer each year that are due, at least in part, to an inherited genetic mutation. So small percentage, but we're talking about relatively large numbers. When you throw ovarian cancer into the mix, smaller number of ovarian cancers, but again, about 20%. So that's another 4,000 cases of hereditary cancer, and that's just across these three cancers. So small proportion overall, but accounting for a fair amount of cancer in the population. Why else are we interested in hereditary cancers? Because getting a positive gene test result for one of these hereditary cancers is highly actionable. Men and women who have positive results have a number of options: cancer screening and risk reduction. So early and more intensive screening for colon cancer, for breast cancer. Options, as you've heard, for risk-reducing surgery. So for women who have a BRCA1 or BRCA2 mutation, in fact, the recommendation is to have a bilateral prophylactic oophorectomy by the age of 35 to 40 or at the completion of childbearing. And that's been shown to reduce ovarian cancer risk. It's been shown to reduce ovarian cancer mortality, and it's been shown to reduce all-cause mortality. So this is a recommendation for BRCA1 and BRCA2 mutation carriers. Also a recommendation to consider a risk-reducing bilateral mastectomy, which reduces breast cancer risk. The links to reduced mortality are not as clear for mastectomy, and so that's why it's not a recommendation, it's a recommendation to sort of think about whether that's an option. There are chemoprevention options that can reduce risk by as much as 50%. And increasingly, we're starting to see some work looking at different lifestyle changes that may moderate risk. So actionable in terms of risk reduction for healthy women and men who haven't been affected with cancer. Increasingly, implications for men and women who are affected with cancer. So for example, men with low-risk prostate cancer, newly diagnosed with low-risk prostate cancer, typically are choosing between having an active treatment like radiation treatment or radical prostatectomy, or active surveillance, which essentially means monitoring the prostate cancer for progression, not treating it unless and until it progresses. If that man is a BRCA2 carrier, for example, active surveillance is really off the table. Should not really consider active surveillance because BRCA2 is associated with aggressive prostate cancer. Surgical treatment can be influenced by genetic test results. So, for example, women who learn at the time of their diagnosis that they carry a BRCA1 or BRCA2 mutation often consider having a bilateral mastectomy as their primary breast cancer treatment to treat their affected breast and to reduce the risk of a future breast cancer in their unaffected breast. Increasingly, we're seeing chemotherapy guided by germline genetic test results at the time of diagnosis. So there are a number of new novel chemotherapeutic agents that seem to be particularly effective in individuals who have certain germline hereditary cancer mutations. And then, of course, there are other implications of a positive test result for the family, for other health care decisions. So clearly, getting tested is actionable and is something that can improve outcomes. So we know that risks are high for men and women who carry these mutations. We know that these mutations account for a fair amount of cancer each year. We know that there's the potential to engage in behaviors that can reduce risk after learning of the mutation. So the next question is, do patients, when they learn that they carry one of these mutations, actually engage in these behaviors? Does the test actually impact behavior? And we've known for a long time that it does. These are relatively old data from our group looking at newly diagnosed breast cancer patients who were offered genetic testing at the time of their diagnosis. And what we found, and what you can see in the yellow bar for women who tested positive, that's the proportion who opted for a bilateral mastectomy. And what you can see is getting a test result clearly impacts surgical decision-making, increases the use of bilateral mastectomy, decreases the use of unilateral mastectomy. So what are we seeing? We're seeing that women who maybe are not candidates for breast conservation and are recommended to have a unilateral mastectomy if they also know that they're a mutation carrier, they often opt to have both breasts removed. Healthy women who learn that they carry a mutation. We see that the vast majority of them, within 5 years of learning that they have a mutation, opt for a risk reduction approach. So nearly 70+% opt for a risk-reducing oophorectomy, and 45% opt for a bilateral mastectomy. Some opt for both, obviously, because that adds up to over 100. So we know that getting a test result does actually impact behavior, and impact behavior in ways that reduce cancer risk. So how frequently do men and women who are candidates for testing, who meet the criteria for testing, actually go forward and get testing? And this is where the results are I think, a little bit surprising. So this is a study from 2011, so going on 10 years. And this is a study of BRCA testing in breast cancer patients. These are newly diagnosed breast cancer patients or patients who've been diagnosed, let's say, in the last year. And there are two things I want you to sort of note. One is that the overall utilization of testing in this sample was pretty low, under 40% for virtually all of the racial and ethnic groups. And these are under 40% of women who meet criteria for genetic testing. So under 40% overall, and you can see clear racial and ethnic disparities. So overall rates are low, And layered on top of the overall low rate of testing, we have ethnic and racial disparities that reduce the rates of testing even further in certain underserved groups. Those are old data. These are new data, and we see the same thing. This is ovarian cancer. So all women who are diagnosed with ovarian cancer should be referred for genetic counseling and genetic testing. That's a guideline that's been around for going on 5 years now. What we see is overall 30% of those patients actually get tested, and we also see ongoing disparities. So 35% of white patients are tested, and somewhere around 20% of black patients are tested. So low overall rates plus disparities. Again, these are recent data. This is looking at this sort of a different way. This is more population-based study. The lower part of the figure is unaffected women, so women who have not been ever diagnosed with cancer. And what this is looking at is the rate of testing from 2005 to 2015. And contrary to what most people believe, there has not been a huge increase in the rate of testing. It's about a 30% increase over those 10 years. And the big blip there that you see in 2013 is the Angelina Jolie effect. So there was an increased use of testing during that year. It's also the year that Myriad lost their patent. So there was also an increase because testing got all of a sudden much, much cheaper. But we see that blip, and then we see the numbers start to come down a little since then. The top bar is women who have previously been diagnosed with breast or ovarian cancer. And the rates there are much, much, much higher for testing, as they should be, or as you would expect. But we don't see an increase at all over those 10 years, from 2005 to 2015. In fact, we see a decrease. So surprisingly, it's not at all clear, despite what we hear about increasing demand, that the rates of testing are going up all that much. Why is that? Well, this is another way of looking at some of these data. And this is pointing to genetic counseling as a possible issue. So what we see here at the bottom, and these are sort of in proportion, we see about 55% of the sample was tested. The vast majority of those who were tested had formal genetic counseling, as you can see by the gray bars there. About 45% of the sample was not tested, and of those who weren't tested, about half did not receive any genetic counseling at all. Is this because they weren't referred for genetic counseling? Yes. Is this because some women were referred for genetic counseling and there were barriers to obtaining genetic counseling and so they didn't have genetic counseling? Yes. So it's both of these things, and it points to potential interventions. So I want to just briefly, we've heard about a lot of these, I just want to briefly go through some of the barriers that we've identified and others, everyone has identified these barriers to genetic counseling and genetic testing. So first, knowledge and awareness. We've heard about this today. This is on the part of providers and is manifested in low referral rates, or the inability of providers to deliver genetic information to patients, to recognize patients who should be referred for genetic counseling and testing. And it's also at the general population level. The way that genetic counseling and, as a result, genetic testing typically works is it's by referral. Either a physician refers you or you refer yourself. And so if knowledge is low up front, referral is going to be low. Access. Access is a huge issue with the traditional model of delivering genetic counseling and genetic testing. How is that done? As I said, a patient who has to first, a patient or someone from the general population who's healthy has to first either recognize him or herself that they're a candidate for genetic counseling, or that has to be recognized by a physician. So there's the first barrier. Then the person has to be referred for individual, and this is changing, but just to generalize, for individual in-person genetic counseling. Typically that first session might last 45 minutes to an hour or more. Patient has to travel to a clinic. Patient then provides DNA for genetic testing if that's what they choose to do. And then when the result is available, the clinic calls the patient back, schedules a follow-up appointment, patient comes in, patient has a session where they learn their test result. Again, this is This is evolving, but this is the traditional model. This creates all sorts of barriers. There are barriers in terms of access. There's patients have to travel a long distance to the clinic, but most importantly, this is a labor-intensive operation, right? To schedule these patients, to see these patients individually. Genetic counselors can't see patients every 15 minutes. It's much more intensive than that. So it's labor intensive, and yet we have a shortage of genetics providers. So we don't have enough genetics providers to deliver genetic counseling in the way that the traditional model says we should deliver it. Beyond a shortage, genetic professionals are not evenly distributed across the country. There are lots of areas in this country where there's not a cancer genetic counselor for hundreds of miles. We've done studies in rural areas where patients just can't get access to a genetic counselor who knows anything about cancer. So there's a shortage, there's an unequal geographic distribution, the referral-based model is not integrated into clinical care, it's not proactive, we're not identifying patients in the clinic. Again, this is changing, I hope, but we're typically not identifying patients in the clinic and having a genetic professional in the clinic who can see patients when they're there. Instead, if they're identified, they're referred out. Patients have to then come make another trip. So this creates all sorts of issues related to time, related to distance that they have to travel, creates socioeconomic barriers. There's the cost of counseling, the cost of testing, there's insurance coverage. But in addition, there are more straightforward barriers like, who's going to take care of my kids? How do I take a day off from work to do this? So all sorts of barriers, most of which we've heard about. I'm not going to go through this, but these are important barriers to counseling and testing. So how do we expand access? I want to talk about some of the studies we've been doing in the clinic to try to expand access. But first, I want to talk about several obvious things at a health policy level. Some of these we've heard. First, we have to align referral guidelines with insurance coverage. There are many, many patients, as you've heard, who meet guidelines for referral for genetic testing, and their insurance won't cover it. There's not an alignment of policy there. And that has to include coverage for preventive options after testing. It doesn't do someone very much good if their insurance covers a genetic counseling session and a genetic test, but then does not cover the actions that they might need to take based on that genetic test. We obviously need to expand training for genetics professionals. Demand is expected to continue to increase beyond cancer. I mean, we're seeing a lot of this is happening in cancer, but as we progress, there's going to be increasing demand outside of cancer, and we don't even have enough personnel to meet the demand within cancer. Training programs are not keeping up with the expected increase, so that's an obvious issue. We need to emphasize the role of genomics in routine clinical care as part of physician training. Physicians need to be competent at identifying patients, at delivering genomic information. So we're not studying that in our team. What we're studying are clinical interventions, and I want to just talk about a couple of them. They've had mixed success, so we can talk more about why that might be. The first was a study we did designed to reduce barriers among newly diagnosed breast cancer patients, and what we did is developed a highly streamlined, highly proactive genetic counseling and testing intervention. The goal was to facilitate the delivery of genetic counseling and testing prior to definitive breast cancer surgery by reducing a wide range of barriers that patients face in accessing genetic counseling and genetic testing. So our approach was proactive and clinically integrated. We identified patients as soon as they got a positive biopsy result. There were times that we had to wait for the patient to be informed of their positive biopsy before we could contact them. We were in the clinic. So we contacted them within 72 hours, and we scheduled a genetic counseling session. The focus here was on being proactive, scheduling genetic counseling, and talking about genetic testing, regardless of whether their physician, whether their surgeon in this case, raised these issues with them at all. We were flexible in terms of reducing barriers by providing the option of telephone or in-person counseling, so patients could have all of their counseling by phone. We streamlined the content of the counseling to really focus on the role of testing in their surgical decision-making at the pre-test point. If a patient came back with a positive test result, then we would expand the focus of counseling to address many of the other issues. But we were not exclusively focused on the surgical decision, but it was the main emphasis. And we delivered this rapidly. So what did we find? We were definitely able to increase the use of genetic counseling. We increased the overall use of genetic counseling during the treatment period. We were able to increase the use of genetic counseling prior to surgery, which was our goal. So most of the women who were randomized to our intervention compared to usual care did end up completing genetic counseling, which was important and it was what we wanted to do. We probably improved psychosocial outcomes as well. So we were able to significantly increase knowledge in our intervention arm. And that's over the short term, which is the important point to increase knowledge, because this is when people are making decisions about genetic testing and about what to do with a positive test result. So we were able to do that. And over the long term, women who were randomized to our intervention were more satisfied with the surgery that they ultimately chose. And that was at 12 months. So that's all the good stuff. We did not increase use of genetic testing at all. The goal of this was not necessarily to increase the use of genetic testing. It really was focused on delivering counseling. But we were surprised that we didn't increase the use of genetic testing because these were all women for whom testing had really important and immediate potential implications. Testing was relatively high in both groups, but there was really no difference. So we were worried. We wondered about that, and what we found, and this is a somewhat complicated slide, but what we found is that if you look at the columns labeled pre-surgery, and that's what we were trying to do. We were trying to get participants to have counseling, and if they chose testing, to have it prior to their surgery. What we found is without their surgeon recommending they do it, none of them did it. It didn't matter that we were in the clinic, that we were delivering counseling, that we were trying to essentially remove the need for a physician referral from the equation. It didn't matter. If their physician, if their surgeon didn't say, you should get genetic testing, they did not get genetic testing. So that was surprising. Maybe it shouldn't have been. Quickly, a second study. This one was also really focused on reducing barriers by using telephone delivery of genetic counseling and genetic testing. So sort of cutting out the need to come into the clinic, to travel to the clinic, to need to get past all of those sorts of barriers. So the goal here was to reduce the barriers, improve access to genetic counseling and testing through remote delivery. Really what we were looking here is to establish that telephone delivery could be used safely and as effectively as in-person genetic counseling. We were looking at costs as well. The focus here, we didn't think telephone counseling was going to be better. We were using a sample that was largely self-referred, so we knew that most of the women in the study were going to get counseled regardless of what arm we randomized them to. We were interested in just showing that telephone counseling was safe and as effective as traditional counseling. And we basically showed that, but with an explanation. So I won't go through this slide in detail. You'll have to trust me, but what this basically shows is that on every single measure of psychosocial outcomes, decision-making outcomes, the sort of genetic counseling outcomes that we thought were important, the groups were statistically the same. This was a non-inferiority design. It was a rigorous statistical design to show that telephone counseling was no worse than traditional in-person counseling. And we were able to show that on every single outcome we looked at, except for genetic testing uptake again. So what we found is that there was an ever so slightly higher rate of genetic testing in in-person genetic counseling. That's not surprising, because by delivering counseling remotely, patients then had to figure out a way, we helped them obviously, but they had to figure out a way to provide their DNA for testing, whereas if they're in a clinic, they could get tested right there. So we weren't bothered by that. We weren't that surprised by that. We were very bothered by this. All of that difference, 100% of the difference in testing uptake, was accounted for by a lower rate of testing among racial and ethnic minority participants in the telephone counseling arm. So there was something going on there that we didn't anticipate, and we're still trying to figure it out, and we've designed some other studies to start to create more targeted and tailored interventions. So just some tentative conclusions, and then quickly a couple of studies that we have in the works. We can improve access to genetic testing, to genetic services, by proactively delivering counseling. by reducing barriers, by streamlining counseling. There are all sorts of options that are less labor intensive than our study. You can have EMR prompts, you can embed staff, you can use navigators or genetic counseling assistants. This is all work that's happening all across the country. But this does not necessarily lead to increased genetic testing. And that's something that we need to figure out. Telephone delivery, again, it increases reach and access. It's safe and effective, but significant barriers remain. Telephone counseling, partially based on that study, is widely used now. It's widely covered by insurers. It's something that's part of clinical practice, but there are still some questions about who benefits and who doesn't from delivering counseling in that way. So we need less resource-intensive alternatives because we're not keeping up with the growth in genomic medicine overall, and we're doing some work in that. We also need to increase knowledge. So there are a couple of just quickly ongoing projects that I want to talk about that our team at Georgetown is leading. The first is a study of at-risk Latina women that is led by Alejandra Hurtado de Mendoza. And here, this is designed to increase awareness and to increase knowledge in the population. She developed a really fantastic video that will be available on YouTube once the trial is completed. It specifically addresses language, cultural beliefs, lack of referral, lack of awareness in this underserved population. And the preliminary results of her trial are very promising. We have another program led by Christy Graves at Georgetown and Susan Veta-Parampil, who is at Moffitt, where they developed a training program to train community health educators, navigators out in the community to develop referral level competence in genetics. So they can identify someone and refer that person, and they have networks. And this is an intensive training program. And then finally, we have a number of projects looking at, again, sort of extending this to look at alternative approaches. We have a study focused on men from hereditary cancer families, where we're using web-based genetic education. We have a study designed to increase the use of cascade testing within families where a mutation has already been identified, where, again, we're using a streamlined electronic approach plus brief telephone counseling, and then just a fantastic study at MD Anderson that we're not involved in, a huge randomized trial looking at an online video and an online result disclosure versus the same video and disclosure but with telephone counseling added in. And I will stop there because I'm over.